Hello guys. Welcome to Dr. Ankit Pharmacology series, and let's discuss about the pharmacology question which were asked in INICET November 2025. So remember, some questions language or options may vary because it is memory based recall, and I have tried my best to recall as authentic as much as possible. पहला सवाल, the first question is the drug of choice for helminthic infection caused by the given parasite. So we can see this is a crab and the color of this crab is orange color. So this is orange, fresh water crab, and it is generally eaten by the people as a delicacy. But when people eat this crab, it can lead to one helminthic infection known as paragonomius. It can cause paragonomius infection, which is known as lung fluke. So it's a kind of a worm. And the drug of choice to kill paragonomius infection is praziquantel. So answer of this question was praziquantel. So let's recall all the helminthic infection which we have learnt in a crisp manner. Was that all helminthic, they were classified into cestodes, trematodes and nematodes. Remember, cestodes, they are known as tapeworm. They are known as tapeworm, and trematodes, they are known as fluke. So if we write the names of cestodes like Taenia solium, which is known as pork tapeworm, Taenia saginata, which is known as beef tapeworm. Similarly, we have Hymenolipsis nana, which is known as dwarf tapeworm, and Diphyllobothrium latum, which is known as fish tapeworm. Similarly, in trematodes, the question which was asked was paragonomius. It is known as lung fluke. Another one very important is schistosomia, which is known as blood fluke. Now remember, for all these cestodes and trematodes, the drug of choice is praziquantel. So in this question, paragonomius was asked, but there are certain exceptions to this rule. So exception to cestodes and trematodes are echinococcus, which is also known as dog tapeworm, and it causes a disease known as hydatid cyst. Here the preferred drug is not praziquantel. Here we have albendazole as a drug of choice. And same albendazole is the drug of choice for neurocysticercosis. Lastly, fasciola hepatica. It is known as liver fluke. And here the drug of choice is triclabendazole. Now about nematodes like Ascariasis, which is known as roundworm, Nicator and Encyclostoma, which are known as hookworm, Enterobius, which is known as pinworm, Trichuris, which is known as whipworm, and Trichinella, which is known as pork roundworm. In all these nematodal infection, the drug of choice is albendazole. And if albendazole is not given in the option, go with mebendazole. Now, again, there are certain exceptions like strongyloids. Remember, strongyloid, it is known as thread worm. Onchocerca, which can lead to river blindness. In these two cases, remember the drug of choice is ivermectin. And lastly, lymphatic filariasis and loa loa. Here the drug of choice is DEC, diethyl carbamazine. So these are all helminthic infection very commonly asked. Now the next question which was asked was that which drug regimen is given in the induction phase in the treatment of cryptococcal meningitis. We have already discussed that if there is any serious fungal infection, we always start with a drug liposomal amphotericin B. So in induction phase, which is given 2 to 8 weeks, we give liposomal amphotericin B. But in cases of cryptococcal meningitis, we add a drug flucytosine, because flucytosine has a synergistic action with amphotericin B. Now imagine a patient of meningitis came to you. You started with liposomal amphotericin B and cryptococcal meningitis. Now after 8 weeks you saw that CSF culture now has become negative. Then we start the patient on maintenance phase, which can be written as consolidation phase. And here we prefer to give azoles because long-term treatment of amphotericin B is generally not given. It is an IV drug plus it is a nephrotoxic drug. For maintenance phase, we give fluconazole. Agreed? So if a question comes induction phase of cryptococcal meningitis, yes, the answer is option number C, amphotericin B with flucytosine. Now the next question is which of the following drugs is a prostacyclin, which is also known as PGI2, receptor agonist, which is used in the treatment of pulmonary artery hypertension. Now the answer of this question is selexipag. How we can remember? We have discussed the trick. I word is coming, that is I. P word is coming, which is prostaglandin. AG means it is a receptor agonist. And this drug has been approved for the treatment of pulmonary artery hypertension. Now, what about eloprost and epoprostinol? Remember, these drugs, they are not receptor agonists. These drugs are rather synthetic prostaglandin I2. Although they will act on prostaglandin I2 receptor, but a specific drug which is an agonist is selexipag. Then we have ambrisentan, and we can see that ambrisentan is ending with the word entan. So it is an endothelin. En means endothelin. An means antagonist. Again, all these drugs are given in the treatment of pulmonary artery hypertension. So let's recall a trick which we have discussed. The drugs which we use for PAH, pulmonary artery hypertension, we can make a mnemonic: Pepsi, Coca-Cola. So these are the drugs given for pulmonary artery hypertension. The first drug of choice for PAH is prostacyclin I2 analogs. So these are analogs or synthetic form of prostaglandin. And there are three prostaglandins which have been approved for PAH. TIE TIE. So we can write treprostinil. So you can see prost word is coming, eloprost and epoprostinol. So these are the three drugs which are given. Then we have endothelin antagonist. Remember, endothelin causes vasoconstriction in pulmonary artery. So we block endothelin receptor by giving an antagonist. It produces vasodilation and pulmonary artery pressure reduces. And any drug which is an endothelin antagonist, it will end with the word entan, like bosentan, ambrisentan. So they are ending with the word entan. Then we have phosphodiesterase 5 inhibitor. These drugs, they will end with the word fill, or you can write fill. A very famous drug like Viagra, known as sildenafil, which is given for erectile dysfunction or impotence, is also approved for pulmonary artery hypertension. Another drug is tadalafil, which is even longer acting drug. Then we have soluble guanylyl cyclase activator. The drug name is Riosiguat. How we can remember Guat? GU means guanylyl cyclase, AT means activator. Then we have a drug which is not a prostaglandin but stimulate prostaglandin I2 receptor. We have very well discussed. The name of this drug is, which was asked in this question, is selexipag. And the trick we have discussed, I2 type of prostaglandin, AG means agonist. Remember, continuous nitric oxide inhalation is also given for PAH. It is a separate question. And calcium channel blockers like amlodipine, nifedipine, they have also been approved for the treatment of pulmonary artery hypertension. Now the next question is, which of the following drug acts on the transporter given in the image? So if we see this transporter, the function of this transporter is to throw back sodium from inside the cell to outside. We can see 3 molecules of sodium, and it brings back potassium inside the cell, 2 molecules of potassium. And it will not work for free. It will require energy. It takes ATP and gets converted into ADP. That means it dephosphorylate ATP. That means it is linked with an enzyme, ATPase enzyme. That means it uses or utilizes ATP. So let's name this transporter as sodium potassium ATPase transporter. And the drug which inhibits sodium potassium ATPase transporter is a very famous drug for heart failure, digoxin. So let's see what are the other drugs we have and on which transporters they act. So the first one we have discussed is digoxin. So imagine this is a cell membrane and this is outside the cell, this is inside the cell. So the first transporter is sodium potassium ATPase, which throws sodium outside and bring back potassium inside, and it will require ATP also. So this is sodium potassium ATPase, and this transporter is inhibited by a drug known as digoxin. Then we have a drug amlodipine. Remember, amlodipine is a CCB. CCB stands for calcium channel blocker, and the work of calcium channel is generally to bring calcium inside. It brings calcium inside. And amlodipine inhibit this transporter. It is a calcium channel blocker. Then we have ivabradine. Ivabradine is a drug for angina, and we call this ivabradine as funny channel blocker. And these funny channels are present on SA node of heart, thereby it reduces heart rate. Now what is funny channel? Remember, funny channel is also known as inward sodium potassium current. The function of this funny channel is to bring sodium and to bring potassium inside the cell. So this is funny channel, which leads to depolarization or firing of SA node, and this channel is blocked by ivabradine. And another drug for angina is nicorandil. Remember, nicorandil is a potassium channel opener. And understand one word, that when the cell is not working, inside the cell we have more potassium, and this potassium moves outside. So this channel is known as potassium channel, and this channel is opened by, it is not blocked, it is opened by a drug known as nicorandil. It is a potassium channel opener. Next question, which of the following drug is not used in the management of status epilepticus? So status epilepticus, we already know those seizures which are not controlled beyond 5 minutes. Seizures are getting continued beyond 5 minutes. We call it as continuous seizure or status epilepticus. And remember always, two drugs which are not used in status epilepticus is ethosuximide, and the second drug which is not used in status epilepticus is lamotrigine, because in status epilepticus these drugs require very high dose in which they can lead to toxicity. So let's see the management of status epilepticus, and we will use the table of Harrison internal medicine book. So if a patient comes to you with status epilepticus, that means seizures are more than 5 minutes, then we start the drug intravenous benzodiazepines. Like the most preferred drug is lorazepam. We can use other drugs also like midazolam, clobazam, clonazepam, etc. Now, if these seizures continue beyond 30 minutes, then we add other drugs. The other drugs we will add depends upon the type of epilepsy. If the patient is having GTCS, generalized tonic-clonic seizures, or the patient is having focal seizures. But overall, which drugs we use? we will use the drug valproate. We can also give phenytoin, and we have a faster acting form of phenytoin known as fosphenytoin. We can also give levetiracetam. So remember, these three options are already given in our question. So these drugs are given in status epilepticus, and if seizures are still not getting controlled, they are lasting beyond 48 hours or 2 days, then we put the patient on general anesthetic drugs. So like ketamine, sevoflurane, isoflurane, thiopentone, phenobarbital. So just remember, we can give any general anesthetic drug. So the next question is, which of the following drug combination is recommended for HIV pre-exposure prophylaxis? So 6 months back, a question came on post-exposure prophylaxis and neonatal prophylaxis. This year question came on pre-exposure prophylaxis. Pre-exposure means that there is a patient which is a high-risk individual, and that high-risk individual can acquire HIV. So those high-risk individuals are men having sex with men, MSM, intravenous drug abusers or IDU, intravenous drug users. So these people are at high risk of acquiring HIV. So these people can take pre-exposure prophylaxis of HIV. So which combination has been approved? The correct answer in among these options is tenofovir with emtricitabine. So overall, remember, there are three combination or three drugs which have been approved for pre-exposure prophylaxis of HIV. So the first which has been asked is tenofovir with emtricitabine combination. This is the only oral drug combination we have for pre-exposure prophylaxis. Another drug we have is cabotegravir. Gravir word is coming. It is an integrase inhibitor. It is given by injection once in every 2 months. And a new drug recently got approved in 2025 is for pre-exposure prophylaxis is linacapavir. You can see cap word is coming. It is a capsid inhibitor. So let's write these drugs. The first combination is known as RTI, which is known as reverse transcriptase inhibitor drug. Cabotegravir is an integrase inhibitor. Grace word is coming in them. While linacapavir is a cap word is coming, capsid inhibitor. And the good thing about linacapavir is it is given as an injection only twice a year. That means it is only given once in every 6 months. So these are the three drugs given for pre-exposure HIV prophylaxis. Next question, an HIV positive patient presented with increased cough, dyspnea and fever, and patient was diagnosed to have miliary tuberculosis. So which of the following statement is true? As we have discussed that tuberculosis is one of the commonest opportunistic infection in HIV. So remember, if any opportunistic infection comes, first we treat opportunistic infection TB. So first we start the patient on ATT, anti-tubercular drug, and after 2 to 8 weeks, we initiate the patient on ART, that is antiretroviral therapy, which is given for the treatment of HIV. Now, why we are keeping a gap of 2 to 8 weeks? Because if you will start ART first, don't you think CD4 count will improve? And if CD4 count will improve, suddenly the body immunity will increase. And if body immunity will increase, it can lead to a syndrome known as iris syndrome, which is known as immune reconstitution, and it leads to inflammatory syndrome. So that is why sometimes to avoid this iris syndrome, we can give corticosteroid like dexamethasone also, because it can be very dangerous. Now there is a problem. When we start ATT, anti-tubercular drug, there is a drug known as rifampicin. And we have discussed that rifampicin is a CYP enzyme inducer. It increases the activity of CYP enzyme, and CYP enzymes degrades other drug. So there is one ART, antiretroviral therapy, dolutegravir. So can we say dolutegravir degradation or metabolism is increased by rifampicin, because rifampicin increases CYP activity. That is why dolutegravir, which is an ART anti-HIV drug, if you are giving with rifampicin, we have to double the dose of dolutegravir. We have to double the dose of dolutegravir if we are giving along with rifampicin. So now can you tell me the correct answer of this question? Yes, the correct answer is B. Initiate ATT with dexamethasone and then give ART with double the dose or increase the dose of dolutegravir. Next question. In the dose response curve, curve B, which is this one, represent the action of acetylcholine, ACH. So we can see this is the dose of acetylcholine, and we are here we are seeing the effect or response. So this is dose response curve. Now B represent when there is acetylcholine alone. Now, which drug is responsible for the curve A? So if we see the curve A, can we say the response of acetylcholine is getting increased? So in simply, the question is asking which drug is potentiating or increasing the response of acetylcholine. The answer of this question is physostigmine. So if we give physostigmine, the action of acetylcholine will increase. The reason is very simple. Physostigmine, it is an anti-choline esterase drug. Now, what is the function of choline esterase enzyme? Choline esterase enzyme normally degrades acetylcholine, as the name is telling you. So, physostigmine, being an anti-choline esterase enzyme, it inhibits acetylcholine degradation. Can we say because of this reason, the levels of or the amount of acetylcholine in the body will increase? So physostigmine increases acetylcholine level in the body, thereby there will be more effect of acetylcholine in the body. The graph will shift upward, there is potentiation. So next question, which of the following statement regarding finerenone is false? So first let's understand, you must have heard about a drug spironolactone. Spironolactone has been modified and we have made a new drug known as finerenone. Both spironolactone and finerenone, they are ending with the word on. Any hormone we know which ends with the word on, that is aldosterone. Remember, both these drugs, they block aldosterone receptor. Both of them, they block aldosterone receptor. So aldosterone is a type of mineralocorticoid. So spironolactone is a mineralocorticoid receptor antagonist, and a new drug finerenone is also a mineralocorticoid receptor antagonist. But the difference is that spironolactone, it is a steroidal drug. It is a steroidal drug. Just like aldosterone, finerenone, a new drug, is a non-steroidal drug. Now let's see the difference between these two drugs. Then we will answer our question of INICET. Now spironolactone, apart from blocking aldosterone hormone, it also blocks testosterone or androgen hormone also. So remember, androgen blockage, yes. Spironolactone also block androgen receptor, while finerenone does not block testosterone or androgen receptor. So I want to ask you a question. If a drug is blocking testosterone or androgen, don't you think it can lead to gynecomastia in males? So which drug causes gynecomastia? The side effect of spironolactone is gynecomastia, and there is a no risk of gynecomastia with finerenone. Now remember, aldosterone is a very bad hormone. When there is any organ failure, let's say heart failure, kidney failure, there is increase in RAS activity, renin, angiotensin, aldosterone activity, and this aldosterone damages heart, it damages kidney. So which drug has a cardioprotective effect? Remember, both of them have cardioprotective effect. Agreed? And which drug will have renoprotective effect? Remember, both drugs they have renoprotective effect. But because of their protective effect, they are used in spironolactone. It has been approved in CHF, chronic heart failure when there is a heart damage. While finerenone, it has been approved in CKD, chronic kidney disease, and one of the common cause of chronic kidney disease is diabetes mellitus. So it has been approved in CKD and diabetes mellitus. Now spironolactone is a very older drug. It has other uses also. Remember, RAS activity increases blood pressure. That is why spironolactone has also been approved for resistant hypertension and resistant edema also. Let's say that edema which occurs in liver failure is ascites. It has been approved. Right now, finerenone has only been approved in chronic kidney disease to prevent kidney damage. Now, if you block aldosterone, blocking aldosterone leads to sodium excretion in urine and it causes potassium sparing or potassium retention. So both these drugs have a side effect of hyperkalemia. But remember, more hyperkalemia is seen with spironolactone, less hyperkalemia is seen with finerenone. Remember, aldosterone increases blood pressure. So if we block aldosterone receptor, they will have antihypertensive effect. So remember, they decrease blood pressure. And more decrease in blood pressure is by spironolactone. That is why it is given for resistant hypertension. Less fall in BP is seen with finerenone. So this is the basic difference. Keeping this thing in mind, let's see the answer of this question now. So is finerenone has a cardioprotective effect? The answer is true. It gets excreted through kidney. Yes, it acts on kidney. True. All drugs almost are excreted through kidney. It causes less hyperkalemia as compared to spironolactone. It is true. It causes significant BP reduction as compared to spironolactone. Now the fourth statement is false. More blood pressure reduction is seen only in cases with spironolactone, not finerenone. So finerenone, we can remember, it is a much more safer drug as compared to spironolactone and no risk of gynecomastia. A patient of dengue fever is having platelet count of 20,000. Now there is no signs of bleeding. What is the appropriate treatment? Now remember, in the treatment of dengue, we are seeing there is no bleeding. There is no mention of shock also. So can we say this is a case of uncomplicated dengue? There is no complication due to dengue. And the mainstay of treatment of uncomplicated dengue is lot of fluids. We can write it as hydration and control fever with paracetamol. Control fever with paracetamol. So remember, the answer of this question is paracetamol. But remember, what about other options? What about platelet transfusion? Platelet transfusion is only given if the patient is having any signs of bleeding. And if the patient is having no signs of bleeding, we only give platelet transfusion if the platelet count is less than 10,000. But in our question, the platelet count is 20,000. So here we will not give platelet transfusion. Now RBC and steroids, they are reserved only in cases of complicated dengue. They are given in complicated dengue, like the patient is going into shock. Only then we will give RBC and steroidal infusion. So this is what the guideline says, that platelet transfusion in cases of dengue is only indicated if the patient is having active bleeding and if the patient is having less than 10,000 platelet without bleeding. Now, only the supportive care is the mainstay of treatment. Hydration and paracetamol is the mainstay, and we avoid giving other non-steroidal anti-inflammatory drug like aspirin because these drugs have anti-platelet action. They increase the risk of bleeding. Don't give other NSAID. So the only drug which is given is paracetamol. While other treatment options like packed RBC and steroids, they are not indicated in uncomplicated dengue. They are only reserved in cases of dengue shock syndrome. Next question. A 32-year-old man of schizophrenia. He was started on haloperidol. Haloperidol is an antipsychotic drug given for the treatment of schizophrenia. Now, this patient came with rigidity, hyperthermia, altered mental status. So don't you think haloperidol or antipsychotic drugs, they block dopamine receptor in brain, especially in basal ganglia, and it can lead to extreme rigidity. Extreme rigidity. And if there is extreme rigidity, don't you think muscles will become damaged? Rhabdomyolysis will happen, and muscle rigidity will increase the body temperature also, hyperthermia. So this is a very dangerous syndrome, and this syndrome is known as neurolept. Why it is known as neurolept? Because antipsychotic drug like haloperidol are also known as neuroleptic drug. It is a dangerous condition, emergency condition. Let's call it as malignant syndrome. Malignant means emergency. So what is the treatment of neuroleptic malignant syndrome? Remember, because it is an emergency condition, stop giving antipsychotic drug and start bromocriptine, because bromocriptine will stimulate dopamine receptor. It is a dopamine receptor agonist, and we can also give a muscle relaxant, dantrolene. So this is the main treatment of neuroleptic malignant syndrome. So what do you think is the correct answer? Yes, B is the correct option. Next question. Which of the following statement regarding dronabinol is false or not true? So dronabinol, we have discussed, NABI word is coming. And I have told you it is a cannabinoid receptor agonist. It stimulates cannabinoid receptor, because in cannabinoid NABI word is coming. Now understand, when a patient takes cannabinoid, bhang, charas, ganja, similar action will come, which is seen with dronabinol. Remember, cannabinoid, they increase or stimulate appetite. So there will be weight gain, a person eats a lot, plus it decreases vomiting and pain. So cannabinoid have lot of good effect in the body. So let's see these options one by one. So it acts via cannabinoid 1 receptor agonist. Yes, it is a true statement. It is used for chronic pain and pain management. Yes, it can be given for pain, but all like neuropathic pain, but right now it is not approved. Where it has been approved? It has been approved for two conditions. When there is a weight loss to stimulate appetite, it has been approved in AIDS related weight loss. It has also been approved for cancer related weight loss. Why? Because it stimulates appetite. Another very good use of dronabinol is it also has anti-emetic action. It suppresses vomiting. That is why it is given for chemotherapy. That means anti-cancer drug induced nausea and vomiting. So if a patient is taking anti-cancer drug like cisplatin, there is lot of vomiting, we can give dronabinol. So the false statement is C. It is largely excreted unchanged in urine. Now understand one point. We know that cannabinoids like bhang, charas, ganja or dronabinol, they enter into brain and we have lot of brain effect. So any drug which is entering into the brain must be lipid soluble. So it is a lipophilic drug. And remember, lipophilic drug, first they are converted into hydrophilic form or water soluble form. So they are first gets converted into hydrophilic form, and then it is excreted out in urine. So don't you think lipophilic drug must be changed or metabolized in liver? So they get change in liver, then they are excreted out in urine. So C is a false statement. It is largely excreted unchanged in urine. No, it is first change or metabolized in liver, then it is excreted out in urine. Next question, match the following drug or toxins with their antidote. We have discussed it many times. Methanol poisoning. What is the antidote? Fomepizole. It is an alcohol dehydrogenase inhibitor. So one is C. Opioid like morphine, codeine, heroin. Antidote is naloxone. So the option is B. Benzodiazepines like diazepam, lorazepam, their antidote is flumazenil. Z word is coming in both of them. And arsenic, which is a metal, we have to give a chelator. The chelator which is given for arsenic poisoning is British anti-leucite, which is also known as BAL. So the correct answer of our question is option number C. So drug with their antidotes. Next question, which of the following statement regarding rifampicin is false? So we already know that rifampicin is an antibiotic. It is given for the treatment of mainly TB, leprosy, etc. So what is the mechanism of action of rifampicin? Rifampicin inhibit RNA polymerase enzyme inside the bacteria. Thereby, it inhibits cell division. And this RNA polymerase enzyme inside the bacteria, it is made by which gene? It is made by RPO, RNA polymerase B gene. Now understand, if there is any mutation in RPOB gene, this rifampicin will not able to bind or inhibit RNA polymerase enzyme. So remember, rifampicin resistance occurs due to mutation in RPOB gene. And this mutation we detect by CB-NAT test, cartridge based nucleic acid amplification test, which is similar to PCR test. Now we have discussed that rifampicin is a CYP enzyme inducer, and it is also a P glycoprotein inducer. And P glycoprotein is a protective transporter which is present in blood brain barrier. So any drug which is identified by P glycoprotein will not allow rifampicin to enter into the brain. P glycoprotein makes a blood-brain barrier. So it is pumped out of the brain by P glycoprotein. The answer is true. We have discussed it many times. Now, rifampicin, remember, it is excreted by liver in bile. And when it is excreted in bile, it again gets reabsorbed from intestine. It undergoes enterohepatic reabsorption. That is why the main side effect of rifampicin is when it is excreted through liver, it causes hepatotoxicity is the main side effect. So now the only thing which is a false statement is C. Remember, fatty food increase absorption. This is a false statement. Remember, rifampicin is rather given empty stomach. All anti-tubercular drug we give empty stomach because empty stomach increases bioavailability or absorption of rifampicin. So C is the false statement. Next question, which of the following monoclonal antibody acts via VEGFR? VEGFR stands for vascular endothelial growth factor receptor. The answer of this question is ramucirumab. Okay, ramucirumab. What about pembrolizumab? LI word is coming. Ipilimumab, LI word is coming. And dostarlimab, LI word is coming. These drugs, they modify or lowers the immunity. So we can write they are immunity modifier. We call these drugs as immune checkpoint inhibitor. And we have discussed them many times. And these drugs, they are given as an anti-cancer drug. So let's focus on ramucirumab. Which drugs act or block VEGF, vascular endothelial growth factor? By blocking vascular endothelial growth factor, they inhibit angiogenesis. Angiogenesis means they block the formation of new blood vessels. Where new blood vessels are produced? Remember, new blood vessels are produced in cancers. So these drugs are anti-cancer drug because cancer cells makes its own blood supply. Angiogenesis is a hallmark of cancer, and sometimes new blood vessels, angiogenesis or neovascularization, it also occurs in retina, like in cases of diabetic retinopathy and ARMD, age-related macular degeneration. So these are the uses of VEGF blockers as an anti-cancer drug, and in eyes we give intravitreal injection into vitreous tumor in diabetic retinopathy and age-related macular degeneration. Now we have certain monoclonal antibodies which block VEGF. So we can remember a mnemonic: Bewafa, Ramu, Ramu bro ki Rani. So imagine there is a bro, our bro is there, brother is there, Ramu. He had a bewafa or disloyal wife or Rani, or you can write a girlfriend. So bewafa means bevakizumab. Ramu means ramucirumab. Bro means brolucizumab. Rani means ranibizumab. Okay, so these are the monoclonal antibody maps which block VEGF. Now, two more drugs which also block VEGF, but they are not monoclonal antibody. Another drug we have is elfibercept. R sept word is coming. Remember, it is a decoy. Sept word is coming. We can use a word receptor. So it's a synthetic receptor which will go with VEGF and decoy or degrade it. Then we have pigaptanib. Apta word is coming. It is an aptamer. Aptamer are small nucleotide sequence of DNA which degrades VEGF. So these are the new drugs and the complete list of VEGF, vascular endothelial growth factor blockers. Next question: which of the following statement regarding rimegepant is true? So I have told you that any drug which end with the word gepant, whether it is rimegepant, ubrogepant, okay, telcagepant, abrogepant, many gepants are there. All gepants are CGRP2 antagonist or blocker. Now, what is CGRP? CGRP stands for calcitonin gene-related peptide. And this calcitonin gene-related peptide is an inflammatory molecule. It is an inflammatory molecule which causes migraine. It causes migraine. So that is why this rimegepant, it has been approved for the prevention as well as treatment of episodic migraine. CGRP are given in migraine. Now let's see why other options are false. It is given subcutaneously. No. All gepants are given orally. It causes vasoconstriction. No. Remember triptans like sumatriptan, ergotamine, which are also given in migraine. They produce vasoconstriction. That is why, because they produce vasoconstriction, they can lead to coronary vasospasm. They are contraindicated in heart disease patient like MI, angina. The great advantage of making Gepant is that they are safe in heart disease patient. It is CGRP1 receptor agonist? No, sir. It is not agonist. It is rather antagonist. Next question. A patient is being treated for MDR-TB, multi-drug resistant TB, in which we give B-PAL-M regimen, presented with tingling and numbness, suggestive of peripheral neuropathy. Which drug cause is the cause? So the answer of this question is linezolid. Remember, linezolid causes peripheral neuropathy. Agreed? It can also cause other neuropathy like optic neuritis. Agreed? Then we have bedaquiline. Bedaquiline side effect is QT prolongation. Q word is coming. Levofloxacin, it also causes QT prolongation and it causes tendon rupture. It is a fluoroquinolone, it can cause tendinitis. And 6 months back, clofazimine was asked, and I have told you, clofazimine was a brown colored dye, textile dye, which was later used in tuberculosis and leprosy. It can cause brown skin hyperpigmentation. These are the important side effects which we have to remember of all these anti-tubercular drugs. Next question. Which of the following is not a side effect or adverse effect of beta 2 agonist? So if you have heard about salbutamol, like drugs which are given in asthma, they are beta 2 agonists. And we have discussed that beta 2 agonists, these drugs, their side effect is 2T and 2H. The side effect is 2T and 2H. T for tremors, most common side effect. In heart, it can lead to tachycardia, increase in heart rate, which manifests as palpitations. It causes hypokalemia. Potassium level in blood will fall. But in blood, they can cause hyperglycemia. They increase glucose level because glycogen breakdown occurs in liver. So which of the following do you think is not the side effect? Yes, not hyperkalemia. They rather produce hypokalemia. So they can cause tremors and they can cause tachycardia. Now remember, beta 2 receptors on blood vessel, they can cause vasodilation. They can cause vasodilation also. So yes, A, B, C are the true side effect. Option which is incorrect is D, not hyperkalemia, it is rather hypokalemia. Which of the following is not an advantage of ketamine? So if we remember, ketamine, which is a general anesthetic drug, it is an NMDA antagonist. It is an NMDA receptor antagonist. NMDA is a receptor of glutamate. Glutamate causes excitation. If you block glutamate receptor, it can lead to sedation and person will sleep. So it suppresses nerves in brain. Because of brain suppression, it is used as general anesthetic agent, GA, and it also has a very strong analgesic effect. Pain relieving property is also there. Now let's see which type of general anesthesia it causes. It causes dissociative anesthesia. Dissociative means the person will become unconscious, but all the protective reflex like cough, withdrawal reflex are preserved. This is known as dissociative anesthesia. It is used as an induction of anesthesia. Absolutely true. It has a very strong pain relieving or analgesic property. So that is why it is given along with opioids like morphine, fentanyl to augment the action. So because of general anesthetic, first 2 point, analgesic property, third point. Now remember, ketamine is a drug of abuse. It has an addictive potential, just like opioid. So remember, it is not given to prevent opioid tolerance. No, this is a false statement. So both are addictive drug. We cannot use ketamine to reduce the dose requirement of opioid. Okay. Next question. Which of the following statement regarding lafutridine is false? Now, what is lafutridine? So you must have heard about the drugs like cimetidine, ranitidine. Now, don't you think it is also ending with the word tidine, lafutidine? So any drug which is ending with the word tidine is a histamine H2 receptor blocker or antagonist. It is an H2 antagonist, histamine 2 receptor blocker. Histamine 2 receptor is present in stomach. And if you block H2 receptor in stomach, it reduces HCl production. It reduces HCl production. And any drug which reduces HCl production is given for peptic ulcer disease, peptic ulcer. But lafutridine is unique. Lafutridine has another action apart from histamine 2 receptor blocking property. Lafutridine also increases somatostatin level. Because it increases somatostatin level, somatostatin reduce gastrin production. It is an inhibitory hormone. By reducing gastrin production, it also has additional acid reducing property. And the third good thing about lafotidine is it also increases nitric oxide level. Now remember, we all know that nitric oxide is a vasodilatory molecule. It increases blood supply, so it increases mucosal blood supply to stomach. So because blood supply to stomach is increased, what do you think will happen to ulcer? So it will promote ulcer healing. So if there is already a ulcer, it causes ulcer healing also. So that is why lafotidine is becoming a very famous drug. So keeping this thing in mind, can we say lafotidine increases mucosal flow? Absolutely true statement. It increases somatostatin level. Yes, it thereby reduces gastrin production. It is an H2 receptor or histamine 2 receptor antagonist. True. Now, which is the incorrect statement? That is C. Lafotidine does not decrease nitric oxide production. It rather increases nitric oxide production. So the last question is, which of the following DPP-4 inhibitor has significant drug interaction with ketoconazole? So DPP stands for dipeptidyl peptidase inhibitor. And these drugs, remember, they inhibit the degradation of incretins inside the body. They increase incretin level by inhibiting DPP enzyme. Incretins like glucagon like peptide 1, which promotes insulin secretion. That is why these drugs are given in the treatment of diabetes mellitus. Any drug which is a DPP-4 inhibitor will end with the word gliptin. It will end with the word gliptin. Now, among them, saxagliptin is the only gliptin which gets degraded in our body by CYP3A4 enzyme. Agreed? No other gliptin has CYP interaction. Now, understand, we have discussed that ketoconazole is a CYP inhibitor. So if you inhibit CYP enzyme, then can we say ketoconazole will increase the toxicity of saxagliptin? So it is the only gliptin which undergoes CYP metabolism. So this is all about INICET Pharma Recall. Best wishes. Keep learning always.